Good evening, everyone. I'd like to welcome everyone to our presentation tonight by Mr. Last on first trimester imaging under ultrasound. To everyone, can I please ask them to not have your cameras on if you are. Right. Okay, sorry everyone. I'd like to welcome everyone to tonight's presentation by Mr. Last. To those who have not been able to, that do not know Mr. Last, he is our qualified sonographer at ERAD Radiology in Namibia. He qualified as a radiographer in 2017 at the National University of Science and Technology in Zimbabwe, and later obtained his master's in medical ultrasound in 2019 at NUST. He further attended courses and conferences on first trimester ultrasound at the World School of Prenatal Medicine in July 2020, and the eSpace Global Web Conference in Heart Failure in 2020. His interest or his experience, he has received further additional training in Doppler ultrasound, cervical assessment, and pre-eclampsia screening from the Fetal Medicine Foundation at the UK, or at the Fetal Medicine Foundation of the UK during 2020. He's privileged to have attended the prestigious hands-on bootcamp in fetal scan during October 2023 at Dr. Louis Pistorius and Dr. Meryl Fenter and Professor Kathy Clover at the Paranama Perinatology Center in Cape Town. He briefly spent time during a part-time radiography and sonography lecture at NUST and Gweri Provincial Hospital School of Nursing in Zimbabwe. And he strives to use his skills to deliver excellent and informative services that provide the best outcome for the referring doctors and the patients he examines as well. He is the founder and CEO of the Medical Imaging Foundation Trust, a charity based in Zimbabwe, and runs an informative YouTube channel called the Medical Ultrasound Academy, which provides further teaching in sonography. And with further ado, I welcome Dr. Last, or Mr. Last, to his presentation.
I greet you all in the name of ethical, holistic, medical practice based on the three pillars of evidence-based practice. So basically, the three pillars of medical ultrasound practice are all the same. It's the pillars of the foundation of medical practice. So the pillars of medical evidence-based practice are patient preferences, research evidence, and clinical experience. So personally, I am ERAD by genotype. So before I begin, let me give you an intriguing story about the penguins. So when a male penguin falls in love with a female penguin, he searches the entire beach to find the best pedo to present to her. Such is the love that we must inculcate towards our patients. Human life is sacrosanct. We as medical practitioners, we cannot afford to perpetuate a milestone of human misery. So today, I'm going to present on the role of the first trimester ultrasound scan to improve the perinatal outcomes. That is maternal and fetal perinatal outcomes. So this is the framework of my presentation, the introduction, indications for ultrasound examination in the first trimester, the landmarks in the first trimester, pregnancy dating in the first trimester. I'm also going to talk about the aneuploid screening, obstetrics abnormalities in the first trimester, and then I'm going to talk about the gynecological abnormalities as well. So, as an introduction, let me say a pregnancy does not exist in isolation. A pregnancy exists inside the maternal organs. So, we have to localize the pregnancy inside the maternal reproductive system, meaning to say that an ultrasound scan in the first trimester basically overlaps between an obstetrics and a gynecological examination. Because we need to know the location, we also need to know the mechanical barriers or the hindrances to the developing pregnancy. So essentially in the first trimester, we do the first trimester ultrasound scan to confirm that indeed someone is pregnant. At the same time, we want to know if the pregnancy itself is viable, is the embryo alive or is not alive. We also need to check the order of the pregnancy. Is it a higher order pregnancy or just a single pregnancy? So we need to also to know the location of the pregnancy itself. Is it intrauterine? Is it extrauterine? Are there other mechanical barriers that can obstruct the pregnancy itself? Basically, this is what I'm going to build on as we do this presentation. Before I go further, I would want to reiterate that the first ultrasound scan examination is essentially an exploratory scan because we really don't know much about the nature of the pregnancy. Is it a single pregnancy? Is it a multiple pregnancy? Is it indeed a pregnancy or is it a pseudo pregnancy? We really don't know all that information. So we really are exploring. We also don't know exactly where is the pregnancy. Is it inside the uterus? Is it in the ovaries? Is the pregnancy in the fallopian tubes? We really don't know. So that's why I said the first trimester ultrasound is basically an exploratory start. So we must treat every pregnancy as unique because it can pose its own unique challenges. The pregnancy complications in one patient are not the same to the second patient. Someone can be having the fibroids in pregnancy, someone can be having an ectopic pregnancy. So we have to treat each pregnancy as unique. So basically, captured here are some of the indications. So the list is endless. Some of the indications for a first trimester ultrasound. So when a patient with amenorrhea or does not know that she's pregnant, she can also come for a pregnancy sonar. When someone is having pelvic sonar, when they are having vaginal bleeding or PV bleeding, when they have got unknown menstrual dates, and then when someone is having a subjective feeling of pregnancy, so they are not really sure, but they are with signs that can show that they are pregnant. So when the uterus is greater or smaller than the dates on clinical evaluation, they can also be referred for an ultrasound scan in the first trimester. So when someone basically the test and then the HCG levels are high, and then the pregnancy is positive, they can also be referred for an ultrasound scan for confirmation of the pregnancy at the same time to also localize the pregnancy. So the other thing is in terms of the knockout translucent measurements or in terms of aneuploid screening. I'm going to talk about aneuploid screening in detail during the course of this presentation. So when exactly do we start to see a pregnancy on ultrasound? Some people, I've seen patients coming to me, they say that I've had unprotected sex for the past 2 days. So check for me if I'm pregnant or not. That's not it. So the ideal time where we can see a pregnancy on ultrasound is when the HCG levels are around 1,800 milli-international units per millimeter. That's where we can visualize the gestational sac. So this is a case of an early pregnancy that I captured on sonar. You're going to see that during the course of this presentation, I've tried as much as possible to put the images that I did here so that we take everything more real. We don't have to rely on images from textbook, because if I present things from the textbook, some of you, they don't really see that these conditions, they really exist in real time. So these are the images, most of the images that I'm going to use in this presentation. I captured them here at ERAD. So what we are seeing here is an early pregnancy that you can see here. You can see this is the uterus that we have. So this is the fundus of the uterus, or the upper part of the uterus. And here, that's our endometrium. Then what we have basically here, that's our cervix. But you can see here, there is a tiny, tiny cystic structure here which does an early gestation that I acquired in 5 weeks in 2 days. So an early gestational sac appears to have, if you have thick holes, we call that the double decidual sac side. So the holes will be very thick. And then inside, you can see that anechoic space containing the early amniotic fluid. So there was a problem with this type of a sonogram that I did. You can see the location of the pregnancy. Of course, yes, the pregnancy is located inside the uterus. You can see where it is. But ideally, the early pregnancy was implanted here in the fundus of the uterus, but you can see it's implanted here toward the isthmus, just above the os. So this type of implantation, it poses a risk of a miscarriage. So you must know exactly how to localize your pregnancy when you are doing your ultrasound scans. So this again is a sonar that I did at 6 weeks and 2 days. You can see here what we have. This is the embryo that is developing there, and you can see the gestational sac that we have. It has got thick holes. This is what we call the double decidual sac sign. And inside, you can see that there's a bright structure that is inside there. That's in the early embryo at this stage. So you can visualize it. So what I am showing now, what I'm trying to explain now, are the landmarks. What is it that makes us to see that someone's pregnant on ultrasound? So it is the existence of a gestational sac. How do you see a gestational sac? By the presence of a thick wall that we call a double decidual sign. So this is one of the landmarks that you are supposed to see with an early pregnancy. So now, let me explain at what gestational age is the pregnancy actually visible with ultrasound scan. So basically, our algorithms or the machines that we use, most of them, they can actually measure an ultrasound scan and predict an estimated gestational age and an estimated delivery when the gestational sac is actually at 5 weeks. So at 5 weeks, that's the ideal time where we can actually definitely see that the double decidual sign is developed, and you can distinguish it from pseudo gestational sacs or other fluid collections that can actually be found in the uterus as well. So if the crown rump length is less than 7 millimeters, and then you don't see a fetal heartbeat, that might be early. That might be early. So the crown rump length for you to see heartbeat in early pregnancy, it has to be 7 millimeters and above. So if you see that you measure the crown rump length and it's above 7 millimeters and you don't see any early heartbeat in the fetus, might imply that the fetus has failed, or that's what is called a missed abortion. So now let me proceed with the landmarks that we use in the first trimester to tell that indeed someone is pregnant. It should localize the pregnancy as well. So what we are seeing here, I zoomed in this image. You can visualize here. That's our gestational sac, and you can see the thick holes. These are the thick holes that we have there to show that it's a sign of pregnancy. But before I go further, let me say the other cystic structure that resembles a pregnancy is what is called a corpus luteum cyst. A corpus luteum cyst will also resemble a gestational sac, and it can have these thick holes. So I'm going to discuss all the illusions that we can come across when you're doing a first trimester ultrasound scan. So here, what we are seeing here, we are seeing a cystic structure inside this fluid. This cystic structure there with echogenic thin walls, and then you can see the other structure that is bright there. This is our early embryo. So you can see that the combination of this cystic structure and the embryo are giving a characteristic diamond engagement ring sign. So this is your embryo, and adjacent to it, this other cystic structure is what is called the yolk sac. So what is the function of the yolk sac? The yolk sac basically is used to provide the early nutrition and oxygenation to the developing embryo before the actual development of the placenta. So for us to see that these pregnancies are likely going to fail, if we see a yolk sac like this in the early pregnancy, it is suggestive of a pregnancy that is going to survive and make it. If you don't see a yolk sac, or if you see a yolk sac that is deformed, that might imply that at one point the pregnancy might fail because the life of the developing embryo is now dependent on the yolk sac. So now again, this year is 7 weeks. We can see that there is a progression of this pregnancy. So this sign that we see, these are the landmarks that we actually use to make sure that someone is pregnant. We use landmarks. We don't guess. So what we have here, you can see that they are in fact 3 cystic structures there. The biggest structure there, that's our gestational sac there. That's our gestational sac. So what we have here, all this one, there's a fluid there, there's a fluid outside, this other sac that's inside here. So this sac that we have here is called the amniotic sac. So you can see here at 7 weeks, we can see an amniotic sac, but we are not yet seeing an embryo or a fetus inside. But we can see another structure there which is outside, which is our yolk sac. So a combination of the yolk sac and the gestational sac gives us what is called the double bleb sign. So a double bleb sign is an indication that what we are having is indeed a pregnancy, even if the fetal core is not yet developed. So you can see here what we have. This is the yolk sac, and then the Vindeline duct is the one that connects the yolk sac to the embryo that's going to develop. So this, you must know, is one of those landmarks. When you're doing a sonar in the first trimester, depending on the stage at which you're doing it, you can see this configuration. So when you see this configuration, you must be confident that you are seeing a positive sign of pregnancy, though we are still waiting for the embryo to develop. But the other sign, the Vindeline duct and the yolk sac are there, meaning to say that we still within our means 7 weeks to have an embryo that's going to develop. But in some instances, the embryo will fail to develop. I'm going to discuss about that as well. Okay. So now I'm continuing with the landmarks in the first trimester. You can see here what we have here that is looking like a grain of rice there, adjusting to the yolk sac. This is a developing embryo there. You can see it there. So we don't have a straightforward pattern of development of these embryos. So For some, they develop early. For some, they take a little bit longer. So you can't just say that at 6 weeks, I must see an embryo in every pregnancy. It might delay a bit. It might also be early for some patients. So I'm going to discuss all the some of the challenges that you can have in early pregnancy when these pregnancies fail. So at this stage, you can see that what we are seeing here is a very, very tiny structure. At times, you might not be quite sure if it is a gestational cell with an early embryo that is developing. I said that when the crown rump length is less than 7 millimeters, you might not see a heartbeat there. So don't rush to say that this is a missed abortion. This might be just an early stage where you cannot not actually see the heart flutter. So I'm continuing with the landmarks. You can see here at around 9 weeks of pregnancy, you can see that the fetus now is taking more of human form. You can see the head there, you can see the face of the fetus, you can see the back there, and at the same time, you can see the lower limbs and the abdomen there. So you can see is a progressive growth that is taking place from the initial images that you saw. So with this image again, you can actually visualize the walls of the uterus like this, the walls of the uterus, meaning to say that we can actually tell this is an intrauterine gestation. At the same time, we can also see that the walls of the uterus are clean, there are no fibroids there which are developing, and there's adequate amniotic fluid right around the developing embryo like that. So with the progression of the pregnancy in the first trimester, basically you can see here is 12 weeks and 6 days. So here you can see that the fetus now is taking more of a human form. You can see the palate bone there, you can see the chin, you can see the face there, you can see the forehead. At the same time, you can see some of the brain structures there, you can see part of the back there, and you can also see the abdomen and the thorax. You can also visualize from here the umbilical cord. So the cord is there. At the same time, you can see the genital tubercle there, meaning to say that there is progressive changes. So the first trimester is actually one of those type of examinations where you see a variation in the terms of the growth of the fetus. From the time you see the gestational sac that is without a developing embryo, to the time that you start to see an embryo that appears like a very tiny grain of rice, to the time that you now start to make meaning of the organs of the fetus like this. So the other thing that is so very important in the first trimester is you must make sure that you are dealing with a living fetus. So the viability of the fetus is very, very pertinent, is very critical. So basically, these are the images that I acquired in 6 weeks, 2 days of gestation. So how do you make sure that the developing fetus or embryo is got a positive heartbeat or is alive? Essentially, you can see here, it's a very early, if you just use your B mode, it is very difficult for you to visualize or to make sure, to make that this embryo is actually alive. So what you do, you use color Doppler. So if you put color Doppler here, you can actually see that there's a red color that is coming in there. That is what is called a heart flutter. So a heart flutter basically tells you that the embryo is alive. So if you see a heart flutter there, you are very much confident that we're dealing with a living or the embryo is alive. So how then do we measure the fetal heart rate in the first trimester? Basically, we don't use too much energy or power to irradiate the developing early fetus. So what we do, we use the L mode. So with your color Doppler like that, or without the color Doppler, you can actually measure from the M trace the heart rate like this. So for some machines, they can use a single peak. For some machines, they can use 3 peaks, depending on the configuration of the machine in question. So if we see this, we are very much happy that we are dealing with a living embryo. So that can also be reassuring to the mother that the baby, the embryo is alive. So the other thing that is so important that most people, they don't understand, you know, All right. So the issue that we really see in the first trimester is what is called the anatomy in the first trimester. So most people, they think that the fetal anatomy is only done when you do the digital sonar in the second trimester, which is not it. The best time to start to check for the fetal anatomy is in the first trimester. That's where we can exclude a lot of pathologies. So we can exclude a lot of pathologies in the first trimester. So there is an examination which is called the anatomy or the anatomy scan in the first trimester. So I have acquired some images here to show you how we can actually see anatomy in the first trimester and how best it helps us to rule out early pathologies in early pregnancy. So you can see here what we have. So this is the fetal head that we have here, and you can see this what we have here. That's the echogenic, the brighter outer structure there. That's the cranial bone that we have there. So that's the calvarium. So if you only look or see the cranial bone like this, continuous like that, it means that this fetus or this embryo does not have any sign of encephalocele. So there's no sign of encephalocele because the cranial bone is actually very continuous, and you can see inside there, those are the choroid plexus there. So you can see that they are almost proportional, the choroid plexus there, and there are no defects. And in between there, you can see the midline falxy, meaning to say that we can already rule out pathologies like hollow prosencephaly. So if you come here, you can actually see that in the first trimester again, I acquired this image like this. You can see these are the eyes of the fetus. It seems like it's facing us. So in this view, if you see both eyes like this, and you can actually measure the interorbital distance like that. If you see this view, you can already exclude conditions like hypertelorism and hypotelorism. At the same time, you can also exclude conditions like cyclopia or cyclops, where a fetus is with only one central eye. So we've already seen that there is no fetal cyclops or cyclopia in that image. So again, I'm continuing the anatomy in the first trimester. It's very critical because that's when we can actually exclude a lot of pathologies. So this image that is here is basically an image that I acquired to show the nasal triangle or this portion of the fetus. So when you see the nasal triangle like that, we can already exclude conditions like palate cleft. So this is the head of the fetus. So with the early trimester, first trimester scan, you can also rule out conditions like polydactyly. So you can actually count the number of fingers of the developing fetus from the first trimester. We don't just see polydactyly in the second trimester. So again, I'm continuing the anatomy in the first trimester. So what we have here, you can see this is the transversation. This is the transversation of the fetus like that, where we are measuring the abdomen. So we can see in this transversation that we can see this cystic structure that's our fetal stomach. So when we see a fetal stomach like that, it's a single bubble like that. It means that this fetus does not have conditions like esophageal atresia. It doesn't have conditions like duodenal atresias. With the duodenal atresia, you can see a double bubble, and this one just a single bubble sign. And also, we can also exclude the conditions like jejunal ileal atresias because we don't see the triple bubble sign. So you can see the rich information that we get in the first trimester. So this other one, again, you can see here, there's another cystic structure that is here that I'm pointing here there. That's our fetal bladder. So essentially, when you see a fetal bladder, it also means that we don't have complete renal agenesis. So the presence of a bladder, it shows that the urinary system is functional, meaning to say that we already know that there is no unilateral renal agenesis. So it implies that. It implies that, but it doesn't solely exclude unilateral renal agenesis. Why? Because the one kid is functioning, and then is the one that is responsible for the urine that we see there. So we cannot exclusively exclude renal agenesis by seeing a fetal urinary bladder in the first trimester, but we can be assured that there is no bilateral renal agenesis. So again, in this view, you can actually see that this is the upper part of the placenta of the uterus. Sorry, this is the upper part of the uterus. You can see this substance, that mass that we have, that's echogenic, that's our placenta there. So if we visualize the placenta like this, it means that we can actually exclude complete placenta previa. This is actually a placenta in the anterior upper segment. So you can basically see that in the first trimester, we are able to localize the placenta and exclude conditions like placenta complete previa. So if you come again here, you can actually visualize the fetal height. This is the fetal height there that we have. So if we see a fetal height in the thorax like that, we are very happy that the fetal height is in its normal position. So we can exclude conditions like thoracic dysplasias. We can also exclude conditions like ectopia cordis. So if you also check the proportion, if you see the proportion of the abdomen to the thorax, you can see that they are proportional. At times, you can have a very wide, small thorax. So if we see the normal proportion like that, we can basically tell that there is no asphyxiating thoracic dysplasias in the developing fetus. So again, in this image there, you can actually see there are tiny structures, but I try to indicate there that the bilateral kidneys are there, just like that. So by merely seeing that, we are very confident that we don't have a bilateral renal agenesis. So again, this is the fetal head. In this view, we can see there's a cystic structure in the center there around the falx there. This is the third ventricle. So if we see the ventricles as well, we are very much happy that we can exclude conditions like ventriculomegaly. We can exclude conditions like congenital hydrocephalus. We can exclude conditions like lobar holoprosencephaly, lobar holoprosencephaly. So again, if we here, this is a different configuration on a different patient that I applied as well. You can see the placenta there. Now the placenta is in the posterior upper segment. And here we can also see the fetal bowels. So if we see the fetal bowels like this, we must really see and check the ecotexture of the bowel as well. If the bowels are too bright or they're bright, we can already suspect cystic fibrosis in the first trimester, and then screening for cystic fibrosis can be initiated early. So again, here is the same. You can see the foot there, and you can see the arms as well. And then in this image, you can see the diaphragm there. The diaphragm is there. So the distinction between the abdomen and the fetus is very clear there, meaning to say that we can also exclude conditions like the diaphragmatic hernia in the first trimester. You don't just wait for the second trimester to do the anatomy scan. So I'm going now to talk about a very, very important aspect of the first trimester ultrasound, what is called the pregnant dating. So pregnant dating is a very critical, because a lot of things in terms of pregnancy management are dependent on the actual dates of the pregnancy. So traditionally, we use the LMP or the last menstrual date for dating a pregnancy. Unfortunately, the challenge of within LMP is that it's memory related. Some patients, they don't really remember their last menstrual dates. At the same time, some they can have variable menstrual dates as well. So it poses a huge challenge. There can be other factors, variables that can actually cause someone as well to have abnormal cycles. So that one becomes a challenge. So we can't really solely date a pregnancy using the LMP. So now, ultrasound is very pertinent in the first trimester. When we use the crown round length, we have got a confidence 95 confidence range of plus or minus 5 days that the date that we get is more accurate. So dating, the best modality to do a dating of pregnancy is the first trimester crown rump length, which we do from 11 to 13 plus 6 days. So that's the best time where we date the pregnancy. So I am now going to expand more on the role or the necessity. Why is it that we really have to date a pregnancy? Why should we date a pregnancy in the first trimester, in the first instance? So the importance of screening, of dating is screening. So as we know that there are other screening tests which are also done to rule out other karyotyping abnormalities or other chromosomal aberrations or aneuploid. So these other tests or examinations which are done, they are time dependent, like the biochemistry. So when we do the free beta HCG and the PAPA, these are done at 10 weeks. So we can't do this biochemistry at the correct time or the right time when we don't date the pregnant, we don't know the dates. So we can actually get wrong biochemistry results because we've done them outside the normal range of the time frames where they're supposed to be done. So again, the plasma protein A test is done from 11 to 14 weeks. The triple test is also done for around 16 weeks. And then the knockout translucent itself and the nasal bone, these are done at 11 to 14 weeks. So you can see that they are time dependent. In the second trimester, again, we do the anatomy scan from 20 to 23 weeks. We can't know, or we won't know that we are at 20 to 23 weeks when we don't get the pregnancy. So the third trimester ultrasound scan is very critical in terms of dating of the pregnancy. That's where we know how far the pregnancy is. At the same time, we can also plan on the delivery time. We know that we are going to deliver at this stage when we get the pregnancy. When also cyclic insertion with those with cervical incompetency is also time dependent. So if we don't know the dates, it can be a problem as well. So this is just an addition of the role of dating in pregnancy. So chorionic villus sampling is also done around 10 to 12 weeks. And at the same time, amniocentesis is also done from 11 to 18 weeks. And then non-invasive prenatal testing are done from 10 weeks of pregnancy. So you see all these procedures, diagnostic procedures, which can help us to actually screen for aneuploid or chromosomal aberrations, are also time dependent. So now, how then do we date using ultrasound? So basically, there are two methods that we use to date in the first trimester. The first one is using what is called the mean seed diameter. So before the development of the fetus itself, or before the development of the fetal core, we can only see the gestational sac and the amniotic fluid that's developing inside. We use what is called the mean seed diameter. So how do you calculate the mean seed diameter? We actually take our two images in transverse and longitudinal section. Then we just add the longitudinal diameter, the transverse diameter, and the coronal diameter, and you will get an average. So the machine automatically calculates the gestational age, and it also gives an estimated date of delivery. So the other method that is more reliable, the one that we use that is so reliable to calculate or to predict the gestational age, or that we use to date the pregnancy, is what is called the crown rump length. So in this neutral position, that's how we measure the crown rump length. You can see this is the crown, the top of the head, and this is the rump at the bottom there. So in this neutral position, that's how we measure the crown rump length, and is the most reliable method to date a pregnancy. So now, let me talk about aneuploid screening. So we are in the first trimester. Why are we supposed to do the first ultrasound scan in the first trimester? So that's what I'm trying to answer. So I'm elaborating to try to answer that one. So we do aneuploid screening in the first trimester. So what is aneuploid? So in some people, they don't really know what aneuploid is. And they know that a normal human being must have 23 pairs of chromosomes, which we call the normal karyotype. So meaning to say that in total, a normal human being must have 46 chromosomes. So, but there are times during someone can have an additional chromosome, like they can have 47 chromosomes instead of 46. That is an abnormal character which is called trisomy. So you can have someone with a lesser chromosome which is having 45 chromosomes. So that is now called monosomy. And then we can also have someone who is having 69 chromosomes. That is now called triploid. So these abnormal chromosomes are what is called aneuploid. So why are we worried about aneuploid screening? Some type of aneuploids, they are compatible with life, but some are not compatible with life. So we must give a chance to the developing embryos who have aneuploids which are compatible with life to give them a dose of life. That's why we are screening for this aneuploid. So what are the three basic chromosomal abnormal aneuploids which are compatible, which may be compatible with life? We do have with trisomy 21, which is your Down syndrome. We also have trisomy 18, which is called the Patau syndrome. We also have with trisomy 18, which is called the Edwards syndrome. So these three trisomies, aneuploids can be compatible with life. So we really have to make sure that the abnormality which the fetus is presenting with is managed or can be managed soon after birth. So the first screening that we do for aneuploid is what is called the knockout translucency. So the knockout translucency is the knockout translucency is the fluid that we have at the back of the skin of the neck here. So this fluid that we have here is what is called the knockout translucency. So the knockout translucency, it helps us to screen for Down syndrome. So most Down syndromes have got an elevated knockout translucency. This one will be thicker. So the threshold that we use to exclude Down syndrome is when the knockout translucency is 3 millimeters and below. If anything goes beyond 3 millimeters now, we flag that the developing embryo is a higher risk of Down syndrome. So this is the knockout translucency. However, when you're doing a measurement with knockout translucency, you must make sure that you are doing it the right, you are measuring the right place. So there can be also a pitfall when you measure the distance between the fetal skin and the amnion. So this brighter structure that you're seeing, that's the amnion. So the fluid that you're seeing here is essentially an amniotic fluid. It's not what we use to measure a knockout translucency. So the knockout translucency is just this fluid at the back of the fetal neck. So the other thing we also use to screen for aneuploid is the nasal bone. So this is the nasal bone that we have here. So there's an echogenic structure that you're seeing there. It appears like an equal sign. There is another echogenic structure that we have at the top there, which is of our skin. That's the skin at the top of the bone there. At the same time, this another echogenic structure. Some people they mistake this one as the nasal bone. That's not the nasal bone. This is the tip of the nose. So this is what we are worried about. So the presence of the nasal bone excludes several aneuploids. So an absent nasal bone is associated with trisomy 21, trisomy 18, and trisomy 18. So when I'm doing the first trimester ultrasound scan, by merely seeing the abnormal knockout translucency in the present nasal bone, we can exclude a lot of aneuploids. So you can see here again, you can see this, there's a lot of edema, there's a lot of fluid around this fetus below the skin like that. So again, this is an abnormal type of knockout translucency in keeping with trisomy 21. So this is the fetus is a high risk of developing trisomy 21. So if we have got this information now, the parents can now decide either to terminate the pregnancy or to keep their Down syndrome. So we must give them the choice. That's why I said when it comes to evidence-based practice, we also give the patient their preferences. So here is an abnormal nasal bone there. There's an absent nasal bone there. If you look closely where I showed you the previous image in this, there is an absent nasal bone. What we have there, some people they think that that's the nasal bone. No, when the nasal bone is present, we must see echogenic structures that appear like an equal sign, like an equal sign. One at the top, one at the bottom. So this one at the top, that's the skin, and this is the nasal tip. So in this patient, basically, we don't have a nasal bone. So the absence of the nasal bone is already placing this fetus at a risk of trisomy 21, 18, and trisomy 18. So the other thing that we screen for, or the other thing that we also use to screen for aneuploid and also the urinary abnormalities, urinary system abnormalities, is when we check the fetal bladder. So you see, this is the fetal bladder. You can see the proportion of the fetus and the bladder. You can see this bladder is very much distended. This is what we call a megacystitis. So megacystitis is another indicator also of aneuploid. So patients that will develop trisomy 21, 18, and 18 normally have megacystitis like that in the first trimester. When the megacystitis happens, when the diameter of the bladder in the first trimester is about 15 millimeters like that. So this is another indicator of chromosomal aberrations. So when we see a distended bladder like this, again, it might be an indicator of renal, of the urinary system abnormality. So when you also go to other conditions like Porter syndrome and the other abnormalities of the urinary system, we can also visualize megacystitis. So the other thing that most people don't check on is what is called the tricuspid floor. Tricuspid floor. As you know that on the heart, we do have a valve between the left ventricle and the left atrium. We also have another valve between the right ventricle and the right atrium. So the valve between the right atrium and the right ventricle is called the tricuspid valve. So the normal flow of blood is the flow goes from the right atrium to the right ventricle. But at times, you find that there's going to be blood that is flowing back. Instead of the blood flowing from the right atrium to the right ventricle, it can flow back from the ventricle to the atrium. So when that happens, that is called tricuspid regurgitation. But there's always some degree of blood flow because of physiology that happens. So what then makes the distinction? When the velocity of blood that is flowing back, when you measure it in ultrasound and you realize that it's 16 centimeters per second above, that shows that there is significant blood flow of blood that we call tricuspid regurgitation. So when there is a tricuspid regurgitation or blood flow of blood from the right ventricle to the right atrium, we must flag that. It's one of the signs of, again, of chromosomal aberrations like aneuploid. So those patients, especially the Down syndromes, they have got a higher chance of having a tricuspid regurgitation. In literature says that 55% of fetuses with trisomy 21 basically have got tricuspid regurgitation as compared to 1/3 of fetuses with trisomy 18 and trisomy 18 who develop tricuspid regurgitation. So the two images that you are seeing here, this is a normal image, this is an abnormal image. Why am I saying this is normal? This is the forward flow. This is the one above the baseline. So what we have here, the flow in the positive direction, and what we have here below the baseline is the basal flow. So you can see that the back flow velocity of the tricuspid regurgitant jet velocity is less than 60 centimeters here in this image, less than 60 centimeters per second, meaning you see that this is a normal flow. So this is normal physiology. And you can see the spike we have here, the spike we have here. So the reduction in velocity of jet here is above 60 centimeters per second, in keeping with tricuspid regurgitation. So this is an image that I acquired. You can see this is a very normal waveform tricuspid flow that we have is very normal. The velocity here is below 60 centimeters per second, meaning to say that is very normal. So I've seen a lot of practitioners who refer their patients. They basically talk about the NT. That's the thing that they mostly talk about. They don't talk about the tricuspid valve. They don't talk about the nasal bone. At times, they also don't talk about the the presence of they don't also talk about screening for other abnormalities like the ductus venosus. They really don't talk about those things, of which they must develop a culture of a holistic approach. We don't have to leave any other screening test, so we have to try as much as possible to utilize all the avenues that we have to screen for these aneuploids. So now, this is an image that I applied of an abnormal ductus venosus. So an abnormal ductus venosus is also an indicator of aneuploid. Basically, those fetuses with abnormal chromosomes, they can also develop a abnormal flow in the ductus venosus. So what is the ductus venosus? You know that when the fetus develops, they are rapidly growing. They need to get oxygen and nutrition as quickly as possible. So God, in his architecture, he created what is called the ductus venosus in pregnancy. This is actually a shunt or a bypass, where there is a connection now between the umbilical vein and the IVC, so that the blood just goes quickly from the umbilical vein to the IVC and then to the right atrium. So this bypass allows quickly oxygen reach and nutrition to reach to the fetal circulation. So that's the role of what is called the ductus venosus. So when someone is born now, this ductus venosus, it closes, and then there will be a remnant ligament, which is called the ligamentum venosum. That's the remnant of the ductus. It doesn't work in after birth. So we don't have a functional ductus venosus. It only functions while we were in our mother's wombs. So a ductus venosus on Doppler basically has got three basic waveforms that are so prominent and that we use to predict if it is normal flow in the ductus venosus or there's a reversal of flow or abnormal flow in the ductus venosus. So you can see here, we do have what this peak that is going down like this. That's the orientation of my probe, but this is the positive side. This is the orientation of my probe. So this is the positive side. So what we have here, the biggest peak that we have, that's called the S wave. So the S wave in a ductus venosus waveform, it corresponds to systolic to ventricular systole. So when there is ventricular systole, we get that a waveform. This other waveform that you see, the smaller one, they are adjacent to this one, that is the early ventricular diastole. Then you can see that there is another one that is going in the opposite direction. This is the baseline. This one is going in the opposite direction. So this is what's called the A wave. The A wave corresponds to arterial systole. So here, this one is abnormal. Why? Because you can see that the A wave is going in the opposite direction of the baseline. So this is there is a reversal of the A wave. So if we see such type of a waveform, it tells us that there can be structural fetal heart problems or congenital heart problems can give us this configuration again on pulse Doppler like that. The other thing, we can have a ductus venosus that's abnormal in those patients who are having abnormal chromosomal defects or aneuploidism. So if we see an abnormal ductus venosus, we must flag that, and then the gynecologist can take it further, so that in subsequent examinations or when the patient comes back again for the second trimester, we make sure that we concentrate the heart to exclude fetal cardiac abnormal defects, or we can send the patient to a fetal echocardiographer so that they rule out structural cardiac abnormality that will be causing reversal of flow. So here I did these two patients separately so that you can see the distinction between a normal ductus venosus waveform vis-a-vis an abnormal ductus venosus waveform. So you can see here the flow is all in the same direction. This is just the orientation of my probe, but this is the baseline, and then this is our S wave there, then this is our D wave, then our A wave. You can see there the depression that we have, where the depression ends, that's our A wave. But you can see the distinction here. You can see here, this is reversing, the A wave is reversing. That's a normal waveform. This is an abnormal waveform. So this is an abnormal ductus venosus. So in the first trimester, we must make an effort to make sure that we also screen for any signs of structural cardiac abnormalities using the ductus venosus. So the other thing also in the first trimester is screening for preeclampsia. So you can see that preeclampsia is one of those conditions which causes adverse perinatal outcome, both for the mother and for the developing fetus. So we use the uterine artery to actually screen for preeclampsia. Preeclampsia does not occur in the first trimester per se. Preeclampsia occurs from 20 weeks of gestation and above. So we only screen it using the uterine arteries in the first trimester, such that those patients who are at high risk of developing preeclampsia are put on low dose aspirin, so that subsequently we can have a positive perinatal outcome. So this is a typical waveform of a normal uterine of a uterine artery, like this. So what happens when someone is not pregnant? The blood flow into the uterus is not that much. But when someone gets pregnant, you know that now the developing embryo needs to feed. At the same time, they also need oxygen. So there is going to be what is called angiogenesis. New vascular channels are going to develop. At the same time, the old vessel, they are going to dilate so that they allow more blood flow towards the placenta to give the fetus, developing fetus, more nutrition and oxygen. So when that happens now, we are going to have a low resistance flow in the uterine arteries to allow more blood to flow. So when that happens, we are going to see that this is our baseline. We are going to see that the diastolic flow there is going to increase. So the diastolic velocity there is going to increase because the vessels are dilated, there's less resistance. So let us compare this waveform with this one, which is abnormal. This is an abnormal waveform. So you can see this is our peak systole, this is the peak systolic velocity there on pulse Doppler, and then you can see here, this is the depression that we have here, that's called a notch, and then we can see here what we have, that's our end diastolic velocity. So this waveform is a normal waveform in non-pregnant women. We have got a higher resistance flow. You can see the distance from here at the top of this, from the depression of the notch there to the baseline is just small. Meaning you say this is a higher resistance waveform. This is a higher resistance waveform. But if we see this higher resistance waveform in a pregnant patient, this essentially means that we are having an abnormal uterine artery that can be an indicator of preeclampsia in the second trimester. So we don't need to see such type of a waveform in the normal pregnancy patient. It's only normal in a non-pregnant patient. We see the notch there. Yes, so I compared the two waveforms here, then you can see them side by side. And you see here, this is the baseline, this is the baseline. You can see the distance from the baseline there. So the end diastolic velocity is just very small here as compared to here. The baseline is here, and you can see all the way up to there, all the way up to here. You can see that the end diastolic velocity is bigger here, meaning to say that there's less resistance here as compared to here. So this is a higher resistant vascular channel. I scanned this patient first trimester. So I select this patient for preeclampsia development in the first trimester. So this is an abnormal ductus venosus as compared to this normal waveform where vascular channels have opened and there's less resistance of flow to blood. So there is an unfortunate incident that I came across while I was doing my sonar here. I saw this type of patient. Unfortunately, this patient did not come for a first trimester ultrasound scan. It only came when he was referred for a detailed ultrasound scan in the second trimester. So it was very sad because I saw what you're seeing here, this echogenic substance that you're seeing, that is the placenta. So you can see the black substance that we have right around the placenta, that's the amniotic fluid. So you can see that this placenta is not attached to the walls of the uterus, so there's no coupling between the placenta and the uterus, meaning to say that placenta is actually abrupted, or it is detached from the uterus. So this is the fetus, and you can see that there was no heart rate. You can see that the waveform is just flat, then there's no heart rate. And unfortunately, so touching, this fetus died while it was sucking its own tongue. Unfortunately, when the placenta detaches, it means that there's not going to be nutrition, no nutrition to the fetus, no oxygen to the fetus, and it dies instantly. So this is what happened. So that was one of the accidents It's so unfortunate, but it happens because we are not coordinated at times, because we don't let the information that that's why I am here today to explain the importance of the first trimester ultrasound scan and what exactly I'm supposed to look at. It's not a matter of you just saying that I've done a first trimester ultrasound scan and I've seen that the baby is alive or it's not alive. There's more to that, like the screen that I'm talking about, also for these abruptions that are likely to develop in the second trimester. So on a good note again, this is a pseudo abruption. You know, initially when you're doing a solar and you see something like that, you also think that this is a floating placenta. This one, if you look at that, you see the fetus there, and you see the placenta just there. So if you just come from one view or one end, you have an impression of an abrupted placenta. Unfortunately, this is not an abrupt placenta. If you change the orientation of the probe, you can see that there's nice coupling here of the placenta to the uterine wall. And if you put color, you can see that there's intra-placental perfusion. So there's blood flowing nicely into the placenta. That's a normal placenta. It's only the angle of orientation of the probe or misorientation of the probe that is giving the impression of a pseudo abruption. So in the first trimester, again, it's also an opportunity for fetal sex determination. So we can also determine the fetal sex in the first trimester using what is called the genital tubercle. So what is the genital tubercle? Basically, a genital tubercle is a bipotental structure, which is actually the precursor of the male penis and the clitoris in females. So how then do we tell that this is a boy, this is a girl in the first trimester? Basically, if we take our image, the patient in neutral position, the fetus in neutral position like that, if we draw a line like this, that is following the spine of the fetus like that, and then we draw another line, that is this structure that we have here is what is called the genital tubercle. So some people, when they see this, they say this is a penis, this is a boy. No, this is what is called the genital tubercle. It is the orientation then of the genital tubercle that can actually distinguish a male versus a female embryo. So here, if you draw a line that is passes through the lumen here of the genital tubercle like that, if the angle between this line and that one is almost 30 degrees and above, then this is a boy. If the line that passes by the genital tubercle and that one which is parallel to the spine like that are almost parallel to each other, that's a girl. Unfortunately, the genital tubercle method is not so much 100% because it needs a skill. If you are not all that skilled, you will miss it and you can misinform the patient. So if you are not trained in it, you can misinform the patient. But if you really are good and competent about it, it might also be very difficult for you to get a nice view of this patient like this, the neutral position of the fetus, because they are too small, they have a lot of space, they will be moving around a lot. So it might be very difficult for you to get a very correct neutral position of the fetus to actually get the genital tubercle and see if it's a boy or girl. The other pitfall again, the umbilical cord is it goes towards the umbilicus, you can mistake that one for a genital tubercle as well. So again, the first trimester ultrasound scan is an opportunity for us to rule out multiple high order pregnancies. Like if you do the first trimester ultrasound, that's when you can tell the number of fetus there is. So it's not enough for you to just do the pregnancy test and say that the patient is pregnant. But we also have to know the number of children, the number of fetuses the mother is carrying. So chorionicity also is determined in the first trimester. So by chorionicity, essentially means the number of placentas that we have. So we have got 3 scenarios that I put up here. So you see here, this is a twin pregnancy, there's a twin there, there's another twin there. But there's a septum that is dividing the 2 twins like that. So if the septum is thickly, as you are seeing that, this is what's called a lambda sign. So the lambda sign is a sign, it shows what is called a dichorionic diamniotic twin pregnancy. So these are not identical twins. Again, if we have now what we have here, basically, we can see that there's a very thin septum that we have. This is what is called the T sign because the thin septum meets the uterus there. It makes almost a T sign there. So this is a T sign. So when there's a thin septum dividing the two like that, that's the sign of a monochorionic diamniotic pregnancy. Vis-a-vis this we have here, you can see that here we've got a twin gestation as well, but we don't have a dividing sector. So basically, this is a monochorionic, monoamniotic. So these are identical twins. So the first trimester is an opportunity for us to actually see the number of fetuses at the same time is also at the same time to actually determine the chorionicity. So here is another case that I did in the first trimester. As I say that we are not here just to explain what they did in textbooks. We are here to show you exactly what happens in our communities, in our society. This patient I did here at ERAD, you can see this is a twin pregnant, the vanishing twin. So you can see here what we have here. That's the gestational sac. This one and this one, another gestational sac. But you can see the sizes. There's a discordance between the two. This one is big. This one is too small. So if you check the two as well, you can see that this one is there is a fetal core inside. There is no fetal core in here. So this discordance automatically they must tell that we are having a vanishing twin, or the nutrition that they are getting is different. This one is growing well, this one is not growing well. So this condition is essentially what is called a vanishing twin syndrome. Were it not for the first trimester sonar, we were not going to know that we are dealing with the case of a twin pregnancy with one of the twins actually vanishing. The other thing that we are also worried about in the first trimester is to rule out cervical incompetence. So cervical incompetence, one of those things which is one of those things which causes miscarriages. So if the cervix is too short, it can actually open and then a miscarriage will take place. So we also have to check the cervix in the first trimester if it is long enough or is it short. If the cervix is short, it's an opportunity around 14 weeks or so to insert a secret so that we salvage the fetus from miscarriage. So what we have here, you can see I did this scan here also at ERAD. You can see this is the bladder there. What we have here, this is the cervix. Unfortunately, if you go a little bit higher here, you can see here there is this space here, which is actually anechoic. This is a continuation of the amniotic fluid. This is an open os. So the os is open here. So if an os is open like that, we are dealing with a case of inevitable abortion. So the baby is on this highway towards the miscarriage. We cannot stop that. So the normal size of the cervix, essentially it has to be about 2.5 centimeters. If anything below that, we are actually have to flag it as a case of an incompetent cervix. So the other going concern that we have in the first trimester again is actually ectopic pregnancies. So ectopic pregnancies are one of the life-threatening conditions that we have seen in recent times because of multiple examinations which are done, the cesarean section, the myomectomies, and all these reproductive therapies that we have. So there are different types of ectopic pregnancies. When you're doing a first trimester ultrasound scan, you must not always assume that because one is pregnant, then it's always a normal pregnancy. We have to localize the pregnancy. So we can have a cervical ectopic pregnancy, we can have a peritoneal ectopic pregnancy, we can have an ovarian, we can also have an ectopic pregnancy in the abdomen, we can have it in the osteo, we can also have it in the ampulla of the fallopian tube, we can have it in the isthmus of the fallopian tube, or you can have an interstitial ectopic pregnancy. So basically in the first trimester, we are really worried about the location of the pregnancy itself. That's why I say there is an overlap in the first trimester between a gynecological and an obstetric scan. So here is a case that I did here again at ERAD. You can see what we have here. It's a uterus. That's the uterus that we have. So there's an echogenic line that you're seeing. That's the endometrium of the uterus. So the endometrium is quite clean. There's nothing inside. There's nothing inside. But if you go at the top part of the uterus, on the anterior part of the uterus there, at the top there, you can see that there is amniotic fluid around. Then there's a fetus there. There's a fetus there. So this is indeed an extrauterine fetus. I measured the heart rate of this extrauterine fetus. You can see the heartbeat was there like that. So This is the heartbeat. You can see the waveforms that is alive. So this is actually an abdominal ectopic pregnancy, and unfortunately, it was also bleeding. It ruptured. So how do we see that there's a rupture of the ectopic pregnancy? The most fundamental thing that we see is fluid in the peritoneal space. So I've just taken these different patterns. So you can see here, that's the hepatorenal space. You can see there's free fluid in the hepatorenal space there. And also there's some free fluid there in the splenorenal recess here. And then you can see there in the paracolic gutters as well. Here there's free fluid, and again, there is also free fluid in the paracolic gutter here. The gestational age of this ectopic pregnancy was basically 12 weeks and 2 days. So if you are not very much so careful when you're dealing with an ectopic pregnancy, if you don't really make an effort to see the position of the uterus and you quickly write to say that I've seen a viable fetus, you're going to miss an ectopic pregnancy. Like this case, you can see the walls of the uterus, they are actually resembling the myometrium. So that's an illusion that we also have to avoid so that we don't get surprises later on with the progression of pregnancy. So this is again another case that I did. You can see that it's almost resembling the initial case that I was talking about of a ruptured ectopic pregnancy. What we have here is now the uterus there, the uterus is there, and you can see there's free fluid there in the left adnexa. There's also free fluid in the right adnexa there, and you can see there's a lesion that we have here. So this lesion that is multilobulated like irregular like this is our ovary. So this one is one of the pitfalls that you can come across when you are doing a pelvic sonar. You can think that this is a ruptured ectopic pregnancy. Unfortunately, this is not a ruptured ectopic pregnancy, but this is an ovarian malignancy. So this is an ovarian cancer. So we have got an ovarian cancer also. We can have fluid right around like that, like that, like that, like that. That's the malignant translate there, malignant translate there, and there. So you can see the salvation again. You can see the effusion, the fluid there, which is localized around the right ovary. So this is in keeping with a malignant transformation, which is not a ruptured ectopic pregnancy. So this is a pseudo ruptured ectopic pregnancy. So you must be very careful. As I say that evidence-based practice is anchored on the 3 pillars of medical practice. You must have the expertise, the medical expertise, and the experience for you to identify or to distinguish an ectopic pregnancy from other gynecological challenges like this, like ovarian malignancy. So the other thing, this is one of the most difficult and challenging things that you can come across to every practitioner. If you are doing a sonar and then you find that there's an intrauterine pregnancy and it's very normal, we normally end there. But unfortunately, there is also an existence of what is called a heterotopy pregnancy. So what is a heterotopy pregnancy? A heterotopy pregnancy is a multiple pregnancy where one or more fetus can be inside the uterus, and then you can find extrauterine fetus as well. So imagine you having a normal pregnancy in the uterus, and then you're having another ectopic outside the uterus. So this is one of the most challenges that we are more concerned about the first trimester ultrasound scan. That's why I say the first trimester ultrasound scan is basically an exploratory type of examination, because we are not aware, we're just going to the jumbled one, but we don't know exactly where we are going to find the animals to kill. We just going anyway. We don't know how dangerous the animals are. So in a heterotopy pregnancy demands that we readjust and we refocus and we do things differently, because we have to do the examination in the whole abdomen to check if there are no other extra uterine fetuses as well. So if you just do the pelvis and leave it there, what if you have got another ectopic pregnancy in the most sponge out there and you miss it, and then this can cause problems with the progression of the pregnancy as well. So the other challenge that we have, the obstetric problems, one of the other obstetric problems that we have that you can find in the first trimester is someone can get pregnant. They get pregnant, and then the gestational cycle develops well, and at the same time the amniotic fluid develops, but the embryo fails to develop. Like this case, you can see what we have here. We have got our gestational cycle intrauterine, yes, intrauterine, yes, But if you look at it, you can see that this gestational cycle is irregular, it's elongated here, it's irregular, but if you check inside again, we don't see a gestational, we don't see an embryo, we also don't see a yolk sac inside. So this condition now is what is called a blighted or an unembryonic pregnancy. So I did this sonar here, and then you can see the pregnancy, yes, is positive. So if we don't do the first trimester sonar, we will give a false illusion to our clients that, yes, you are pregnant, but it's a failed pregnancy already because the fetus has failed to develop. How then do we say this is a blighted ovum? We don't just rush when you see that there is a gestational state without a fetal core inside and say that you are having a blighted ovum. No, 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 no. The diameter, the mean sac diameter, if you measure the diameter, it has to be 2.5 centimeters above. If you see a gestational sac that is measuring above 2.5 centimeters without any intrauterine fetal core, you have to flag it that is likely a case of a blighted ovum. So the other challenge that we have in pregnancy is what is called uterine dehiscence. Due to the higher number of myomectomies which has been done currently, and also the higher number of cesarean sections, we are likely to have challenges with what is called uterine dehiscence. So if you can see this image here, you can see the part of the myometrium there is missing. So when there is separation in the previous cesarean scar there, and there's a gap that we have here, which is called the scar diaphragm. This area is an area of weakness. So if someone is pregnant and they have with the scar diaphragm like that, it's a weakness area where the uterus can also rupture and the developing embryo is going to be expelled to the peritoneal space. So when you do the first trimester sonar before the fetus big and it doesn't have much pressure, we can actually flag that there is uterine dehiscence there. So the other challenge that we have is the polycystic ovarian syndrome. Most people, or in most cases, patients with polycystic ovarian syndrome, they might be infertile, but there are times during they can be fertile. So in the event that one is with polycystic ovarian syndrome that are diagnosed and they are pregnant, you know, the problem is if you just do a pelvic ultrasound scan and then you are satisfied that the fetus is intrauterine viable, you're going to say it's a normal report. But if you miss polycystic ovarian syndrome, you are done for. Why? Because they are associated with the high risk of higher blood pressure in pregnancy. They are also associated with the higher risk of developing preeclampsia in the second trimester. They are also associated with the development of gestational diabetes. At the same time, they can cause miscarriages and it's still bad. So imagine you're a practitioner dealing with a patient and then everything is normal. All of a sudden, those complications, they come in due to PCOS. So I said in the beginning that a first trimester ultrasound is with an overlap between a gynecological and an obstetric ultrasound because we cannot ignore the obstetric abnormalities that we also come across. So the other problem that I've seen is the problem what's called pseudocyesis or a phantom pregnancy. When one thinks that they are pregnant, their beta HCG level can get elevated, and then they develop signs of pregnancy, like we are seeing here. I've seen a number of patients coming to me saying that I'm pregnant. At one point, I saw a patient who was saying, I'm now 12 months pregnant, so I'm now 12 months pregnant, so I'm overdue for the pregnancy, and the abdomen was big. Then I did the sonar, there was nothing. So this is a case again of a phantom pregnant. This is one of the most challenges that we can also come across, or that you can also give reassurance. So if we do a first trimester ultrasound, we can reassure the patient that there's nothing such that they get to terms with their condition is early when they've not bonded with the developing abdomen without a fetus inside. So here is the case that I can stand in ERAD here again. You can see what we have here. That's a uterus. And then they came and said that we are pregnant. So when I did the sonar, they don't have PV bleeding. When I did the sonar, this is what I found. what I only saw there is that this fibroid there in the posterior myometrium. At the same time, you can see that there is a heterogeneous myometrium there, the heterogeneous myometrium there, and there is blurring of the endometrial myometrium that you can't really distinct here. So this is in keeping with adenomyosis. So it is a non-pregnant case. The other thing that you can also find in the first trimester is what is called a subchorionic hematoma or hemorrhage. So you can see this is our gestational sac, and then you can see there just outside the gestational. There's also another collection there. This is the subchorionic hemorrhage. So a subchorionic hemorrhage can cause PV bleeding, and it can masquerade as a miscarriage, or actually when a subchorionic hemorrhage happens, a miscarriage can also follow. So the other thing that is a time confused by some is a subchorionic cyst. This is a subchorionic cyst there. It's on the side of the amniotic fluid. It's not extra. It's not outside the chorionic sac like that. So this one is no clinical relevance. So if you see a subchorionic hemorrhage, there's nothing to worry about that. They do happen in pregnancy. They don't have any clinical relevance. But when you see a subchorionic hemorrhage there, you must flag it up because it might end up in a miscarriage. So the other unfortunate incident is this case that I did also here. You can see that I tried to check for the fetal heart rate using my color Doppler there. There is nothing there. There is nothing there. So if the fetus dies below 20 weeks of gestation like this, that's a case of what is called induced abortion. So the pregnancy is basically failed. So it's an opportunity again in the first trimester to make sure that whatever the mother is carrying is something that's alive or is something that is dead. So you can see if you just do the pregnancy test, then you say that you're pregnant, you leave them to go, they will be carrying something that is dead like that. So the other thing also that we can come across, that we can find early, that we can pick early in pregnancy is what is called a molar pregnancy. So a molar pregnancy can be complete or it can be an incomplete molar pregnancy. So ideally, what happens with a molar pregnancy, someone gets pregnant, and then the placenta develops, the gestational 6 days, the placenta develops, but the fetus fails to develop. So with time, when the placenta keeps on growing like that, it will start to die, or segments of the placenta, they are going to die. And then you can see cystic spaces that we have here. This is what some call the typical honeycomb appearance or the grapevine appearance. So the grapevine appearance here represents what is called hydropic degeneration. So in the first trimester, we have already seen that the patient is having a failed pregnancy. There is that is a molar pregnancy, which we can't tell if we don't do the first trimester ultrasound scan. However, a molar pregnancy can also be seen when the beta HCG levels are elevated above 100,000. So if there's a sudden spike of the beta HCG, you can predict clinically that someone might be having your molar pregnancy. But however, can we conclude the molar pregnancy without a first trimester ultrasound scan? So here is one of the cases which is very rare that we captured also here at ERAD. What you see here, we can see there is hydropic degeneration of this mass that we have here. So this is the left adnexa. So you can see here, this is the left ovary there. What we have there is a rare case of a molar pregnancy, ectopic molar pregnancy in the left ovary there. So you can see that we are taking things from the blues. These are the things that we live within our communities, where they are not just textbook things, they are reality. So there is really a need for the first trimester ultrasound so that we can exclude things like this, like an ectopic molar pregnancy here situated in the or located in the left ovary. So again, only yesterday I was here with Dr. Jegetera. We had this case which was so much ambiguous. So the doctor was suspecting that we could be dealing with a case of an ectopic pregnancy. However, I tried to do the sonar, and then I survived the whole abdomen. There was no sign of an ectopic pregnancy. What I saw was this abnormally thickened endometrium like that. So if you look closely at the endometrium, you can see that it with focal cystic spaces which are starting to develop. So according to the sonographic appearances, I suspect that this is a case of a molar pregnancy. However, there was a contradiction with the clinical findings. So the beta HCG level were only measuring 6,000 milli-international units per millimeter, of which normally with the molar pregnancy, we expect a spike of the beta HCG levels. That was unfortunate. So the patient is still here. We are still trying to figure out what it could be. However, with the literature, when I was reading yesterday again, I found the case where they said that we can have a perfectly molar pregnancy with HCG levels which are not so elevated. So they will appear like the same with a normal pregnancy. So this is one of the ambiguous cases because the clinical findings, they are not quite correlating with the sonography findings. It might be we have missed something somewhere. So again, this is a case of a partial molar pregnancy. So a partial molar pregnancy is different from a complete molar pregnancy because we can have a fetus that develops at the same time coexisting with a molar mass like this. You can see there's hydrotic degeneration that is taking place there. But in a partial molar pregnancy, the fetus that develops there, it will have multiple abnormalities, congenital abnormalities. That's the distinction. So we can start to repeat that in the first trimester of gestation. So the other thing is, we can also have, most people, they think that when they are having these ICUs in place, they are foolproof or they don't get pregnant. However, we've seen a number of cases where someone is having ICU and Mirena and C2 and they still go on to get pregnant. You can see here, you can see this one is a Mirena there that is embedded in the myometrium. At the same time, you can see there is the pregnancy. So if you do a first trimester ultrasound scan, it's an opportunity for you to flag that there is this complication and you quickly refer that patient to a gynecologist so that the patient gets managed before other complications start to ensue. So you can see here, this is the non-gynecological case that I did also at ERAD here. You can see here is the copper T there, which is an IUCD, and you can see the myometrium is here, and you can see that the copper T is purely embedded in the myometrium. So these are the challenges that person can get pregnant. When they get pregnant, it becomes a challenge. So again, the other challenge that you can have is an incomplete miscarriage. So the miscarriage can also take place in the first trimester. PV bleeding is there, but you can't tell that the PV bleeding is due to a miscarriage. So when you do a first trimester sonar, we can actually see that we have RPOC is there, or everything is clear. So again, we can naturally have a thickened endometrium without someone being pregnant. So this is just endometrial hyperplasia. So how do you distinguish this? So this one is just thickening of the endometrium without any signs of pregnancy, or when someone is not pregnant, then they have got a persistent thickened endometrium. So the other function or the other role of the first trimester ultrasound scan is to make a diagnosis of higher order pregnancy or multiple fetuses in the same pregnancy. So here is a case I was reading yesterday on Twitter. I saw this article there which was saying that mom overwhelmed after birth of quadruplets. So you can see these are called high order pregnancies. So we can decide in the first, or the couple can decide the first trimester that I am carrying 8 fetuses at once. So I need to reduce and to remain with 2 or with 1. So under ultrasound guidance in the first trimester, that's the ideal time where you can do a selective fetal reduction. So because of the assisted reproductive therapies that we have, normally we are now having mothers that are having multiple fetuses at the same time. So the first trimester is the ideal time for selective fetal reduction, so that if you do it beyond that, there can be problems with miscarriage. So everything can miscarry, but when this is done in the first trimester, it can be okay. So there are multiple fetal abnormalities can be diagnosed in the first trimester. So I'm not going to go through all. So we can have anencephaly, holoprosencephaly, encephalocele, pathology of cantrial, gastrocystis, omphalocele, lymph body wall complexes, cystic hygromas, and lymph defects. So there are multiple. When I was discussing about the anatomy of the first trimester, I was talking about how you can exclude pathology in the first trimester as well. So you can see here, this is the case of an anencephaly. There's the face is there, but you can see, you not see the calvarium there in the brain has been eroded. So this is anencephaly. Again, this is cystic hygroma, fluid around the baby like that. And then here we can see that there's a huge encephalocele, and then the fetal cases are a bit collapsed. So this is what is called a pathology of country, or you can also exclude these ones in the first trimester. Then we can also have what's called the physiological herniation. So during the development of the baby, before they reach 12 weeks, they can have a bulge there where the umbilicus are attached. Then you can mistake that for an omphalocele. So a physiological gut herniation, basically it disappears at 12 weeks of gestation. So if it persists, then you must make a diagnosis of an omphalocele. So gastrocysts, again, in the first trimester, you can see the bowels there, they are free floating, and you can see this color there, that's our placenta, our cord, sorry, on the left side. So also you can see conjoined twins in the first trimester like this. So especially in the monoamniotic twins, which are mostly associated with multiple abnormalities. So twin pregnancy is always a risky because it can come up with all these abnormalities. So it's an opportunity for you to make sure that you make a diagnosis of twin gestation in the first trimester. So we can also have uterine congenital abnormalities like diadeps, biconjoint septic uterus. So when you have those congenital abnormalities, the uterus, they can also cause to have complications during pregnancy, like with the horns of the biconjoint uterus can be too small, and then it's associated with miscarriage. So you can see here, this is a case of uterine diadeps. You can see this uterus here, there's a fetus there, but there's no fetus in the other uterus there. So one uterus is pregnant, the other one is non-pregnant. So these are some of the things that we also see in the first trimester. But we have seen that there's a diadem uterus, so already you know that there's a risk of a miscarriage by virtue of a diadeps, of a congenital abnormality of the maternal uterus. So the other thing, as I said, we must embrace the holistic approach. Is we also cannot exclude other conditions like cervical cancer like this. If you see these other maternal problems, you have to flag them as well. Here you can see that this is another sigmoid colon cancer there. If you happen to see, especially in the first trimester, when you do TVS, you can pick these congenital abnormalities. These abnormalities like the sigmoid colon, you must also flag and report on them. We cannot ignore a cancer because we are focusing on a gynecological or obstetric case. So you can see here, fibroids again can cause challenges. You can see here we have got a pendulated fibroid in pregnant there. So if a pendulated fibroid can twist and it can cause a lot of severe pain, and then it can be mistaken for an ectopic pregnancy. So you see here again, this is a fibroid there that is pendular fibroid that is interspaced between the bladder and the amniotic fluid, and in this case, it is giving a pseudo-funneling there. You can think that there is a cervical incompetence, which actually is not there. So the intramural fibroid here again can compete for space with the developing embryo, and it can actually cause miscarriage. And this is another submucosal fibroid also that can be mistaken for a gestational sac. Then you can see here, we also have got a calcified fibroid here. A calcified fibroid can also be mistaken for a fetal head in the first trimester, or it can be mistaken for a dead fetus, which is calcified or petrified, we call a lipopedon. So again, you can see there's a huge or a big polyp there, and then the gestational cells are touching on the polyp there. So this is one of the challenges. If a gestational cell are touching on the polyp like that, this pregnancy is not well coupled to the placenta, so there's a risk of miscarriage there, or a detachment of the sac from the polyp, and then a miscarriage will ensue. So the other pitfalls that we have also are the corpus luteum cysts and a hemorrhagic cyst. The corpus luteum cyst can also resemble in ectopic pregnancy. So if there is a coexistence of the corpus luteum cyst and a normal pregnancy, you can think that there is a heterotopy pregnancy. And then a hemorrhagic cyst in the ovaries can also cause a lot of pain, excruciating pain, and then it can be mistaken as an ectopic pregnancy as well. So adenomyosis is one of the challenges that we have. When someone is having adenomyosis, they carry a risk of miscarriage, preterm birth, then fetal growth restriction, and then preeclampsia, placental malposition, and increased cesarean rate. So there are different forms of adenomyosis. You can see it can present as a focal lesion like this. It can present as an area of angiogenesis of hyperperfusion, focal area of hyperperfusion there with cystic spaces. You can see this is focal adenomyosis. You can see this is hyperperfusion and thickening of the anterior wall of the myometrium, and that this is focal adenomyosis. So adenomyosis is basically ectopic myometrial tissue, endometrial tissue that is found inside the myometrium. So because of the high prevalence of cesarean sections and myomectomies, we now see a lot of pregnant, a lot of women developing adenomyosis, which is a form of endometriosis. So it can present as a diffuse lesion like this with this, what are called the Venetian glands. It can present as a focal posterior lesion there in the uterus. It can also present as a heterogeneous uterus like that. It can also present as a cystic spaces, endometrial cystic spaces like that. You can also see an indistinct border of the endometrium and the myometrium there, and also the same here, which are all forms of adenomyosis. So you can see here a focal lesion there in the scar tissue, and then this area again, which is with cystic spaces in keeping with adenomyosis. So you can also have got adenomyosis like this, like that, and then you can see a cystic space that we have there. This is not an ectopic pregnancy, but this is just an aborted cyst that can be mistaken for a pseudo pregnancy. So the other challenge that you can have, gynecological challenge that you can have, is what is called an aborted cyst. So an aborted cyst does not have a problem. It's small, but big and aborted cyst, they can actually block the labor passage, and then they can complicate normal pregnancy delivery. So in conclusion, the first trimester ultrasound is an opportunity for sonographers referring clinicians to actually give a pregnant patient, an opportunity to get the best positive perinatal outcomes. So it must be inculcated in the medical jurisdiction of good practice that a first trimester ultrasound scan must be done without fail. Any questions?
Okay, thank you, Mr. Lust, for the informative presentation. I suppose we have learned a lot. There are a couple of questions. The first question is from Bonaventure, who says, when the yolk sac and the vitelline ducts are seen in an extrauterine structure and the double blade sign appearance is seen, is that an early pregnancy abnormality?
The yolk sac does not develop in isolation in pregnancy. The yolk sac is found inside the gestational sac, but it will be outside the amniotic sac. There are different sacs. I highlighted that there are three sacs. The bigger sac, which is containing everything, is called the gestational, the chorionic sac. Then there is another small sac inside, which is the amniotic sac. Inside the amniotic, that's where the fetus develops. But the yolk sac, it will be outside. The yolk sac basically is outside the amniotic sac. It is found or located in a space which is called the exocolonic cavity, just outside the amniotic sac.
Thank you. Next question is by Eliud, who says, what is the best plane to take measurements from in a case where the mean sac diameter is used for dating in a machine that uses one measurement to give, to give age?
Because I say that the best predictor for dating is the crown rump length. So in early stages, if you have got a machine which does actually accept a single measurement, a normal gestational sac is more oval shaped. So you take the longest measurement. That's what we take, but we don't really use that one. That one is a rough estimate of the estimate the sickness candidate. We don't date using the mean sake diameter or the sake diameter. We use the crown. So we just wait for the crown rounding time, and then you take one single measurement of the crown round.
All right, the next question, is it wrong to invert the cardiac waveform while taking cardiac activity measurements?
There is nothing wrong about that. That's the direction of flow. That's the direction of flow. So it all depends on how. If you are doing the cardiac, if you are doing the cardiac scan, and then we are doing the ductus venosus scan, and then the fetus is lying facing up or in bridge presentation, the waveform will be the blood will be on the facing the opposite direction. If the patient presents in the cephalic position, the direction changes. So it's not about the direction, it's about the nature of the waveform itself. Are you seeing all the three waves in the same direction? So it's not about the orientation, it's not about the direction, it's about the direction of the blood flow can change depending on how the fetus will be lying.
Sorry. All right. I think there was another question as well. Sorry, Mr. Last.
No problem.
Just get to. Okay, it says that okay, again from Bonaventure, it says I thought the echogenic fetal abdomen appearance is consistent with meconium peritonitis, but Mr. Lass said something like cystic fibrosis.
Okay, meconium peritonitis is an inflammatory process. So that one, the transient can be caused by a lot of factors. But we don't screen for peritonitis. We don't screen, because that's an inflammation. Infection can take place at instant. What we screen for is the cystic fibrosis. This is a condition, that's a fetal condition, that's a congenital problem. So we are talking about screening in the first trimester. So if you see meconium peritonitis, it's a transient case of inflammation. But when we're talking about cystic fibrosis, we're talking about a condition that is here to stay, that we need to screen off. So that's what I'm talking about in terms of the screening. But also, when you're doing the second trimester scan, when you see the echogenic bowel, it can also imply meconium peritonitis. But meconium peritonitis, we don't screen for it because it comes at its own time.
Okay, and then I suppose the last question, is the double bubble sign the only sonographic appearance to diagnose duodenal or esophageal atresia?
It all depends on the orientation of the probe. Are you in transverse or are you in longitudinal? When you are in transverse section, yes, you see the double bubble sign. But when you are in transverse, you see the double bubble. But when you're in longitudinal, you can see two communicating cystic structures. That is used to make a diagnosis of duodenal atresia. But when it is the ilioduodenal atresia, now we are talking about three different cystic structures.
All right.
Are there any other questions?
No, I suppose everybody is saying, yeah, everybody's saying that it's been a very informative presentation, very well detailed presentation as well. So, yeah, it's a pleasure, Mr. Bonaventura. I suppose, yeah, everybody's saying it's been a very informative presentation. And that thank you for answering all the questions that have been asked. Can I just ask that before I move on to the next slideshow, that everybody gives their feedback as in the chat as well, before logging off the meeting. Okay. And before we log out, I suppose it's just time to give a presentation or information to our new sonographer that has started in Mochibarongo, to our doctors that have from Mochibarongo that have joined the presentation. Mr. McDonald Piri, who has some experience in the first trimester, 11 to 13-week scan, preeclampsia screening, as well as cervical assessment, as well as placenta, accretia spectrum, and fetal Doppler ultrasound, and additional training in fetal abnormalities, as well as basic fetal cardiac scanning as well. He has further training or scanning experience in abdominal ultrasound, pleural ultrasound, pelvic, as well as transabdominal ultrasound and breast ultrasound, and will be attending the same training that Mr. Lass has attended last year at the Panorama Perinatology Center in Cape Town as well. He will be attending that as well, coming up in August. And lastly, also some a thing to announce as well to our doctors is that we have added our 4D imaging to our ERAD radiology practice at Walvis Bay. So those that have liked to refer their patients for souvenir ultrasound in 4D imaging, as well as 4D imaging as part of the anomaly screening during the 20 to 24 week period as well. It is being offered as part of our screening in Walvis Bay as well. And lastly, before we sign off, is to have our doctors in Walvis Bay take part in our ICD-10 coding survey to help us shape the future of Namibia's ICD coding practicing. So the link will also be shared now in our chat as well, so that you are able to so that you are able to give feedback that is invaluable and will remain completely confidential as well. We will share the link now in our chat, so that you are able to give your invaluable give your invaluable response as well to what is needed as well. Yeah, so the link to the ICD-10 coding has also been shared in our chat. To those that are based in Walvis Bay, you can give your feedback, and it will be highly appreciated if you can give your feedback and know who needs further training in ICD-10 coding as well. And without further ado, we'd like to say thank you to everyone that has attended the presentation, to anyone that likes to stay up to date with what is happening in the world of radiology and new developments at ERAD. Please sign up for our newsletter as well at www.eradradiology.com/doctors as well. And do follow us on our Instagram pages, as well as our Facebook and our LinkedIn and our YouTube channel as well, at ERAD Radiology. And we'd like to thank everybody for attending, and once again for Mr. Lass for providing a very informative presentation. The next topic will be presented on the 7th of August as well by Mr. Lass as well, that will be pertaining to preeclampsia monitoring with the use of ultrasound as well. Just an addendum to the presentation that was presented.